Welcome back. Today we're gonna talk on the complex interplay of metabolic syndrome in cardiorenal and hepatic dysfunctions. Now, the study of metabolic syndrome has evolved over the past century with several key researchers contributing to the understanding. In 1923, Swedish physician Eskil Kailin first identified the link between high blood pressure, elevated blood sugar, and gout, laying the groundwork for recognizing metabolic dysfunction. Later, or fast forward in 1988, American endocrinologist Gerald Riven introduced the syndrome X, emphasizing insulin resistance as its central feature. Beginning in 1998, Global Health Organization, including WHO, NCEP, ATP3, and IDF, refined the diagnostic criteria, which today define metabolic syndrome based on the presence of at least 3 out of the 5 key risk factors listed on your left. In 2009, a joint statement from major health organizations, including the IDF, American Heart Association or AHA, and WHO established a standardized definition of metabolic syndrome. The diagnosis requires the presence of 3 or more of the following criteria: abdominal obesity, elevated triglycerides, low HDL cholesterol, high blood pressure, and elevated fasting glucose. This classification helps improve global awareness and management of metabolic syndrome, which is a key risk factors for cardiovascular disease and type 2 diabetes. Now, the different expert groups have established diagnostic criteria for metabolic syndrome, each emphasizing slightly different aspects. The most widely used definition come from NCEP, ATP3, and IDF, both of which assess waist size as a key factor in metabolic diagnosis. In contrast, organizations like AACE, WHO, and European counterpart or European group of insulin resistant focus more on insulin regulation. Despite this variation, metabolic syndrome is generally diagnosed when an individual presents 3 or more key risk factors. Differences in metabolic syndrome criteria shape treatment strategies, influencing whether the focus is on cardiovascular risk reduction or metabolic dysfunction management. Healthcare providers must understand this distinction to deliver personalized evidence-based care tailored to each patient's needs. As research continues to refine metabolic syndrome diagnostics, a more individualized approach may improve clinical outcomes. Selecting the most suitable metabolic syndrome criteria depends on patient-specific health concerns. NCEP, ATP3 ideal for primary care and general screening. IDF best for assessing obesity-related metabolic risk with a focus on waist circumference. WHO and the European counterpart prioritizes insulin resistance and diabetes prevention. The American Heart Association addresses heart disease and vascular health concern. The AACE tailored for metabolic endocrine disorders, emphasizing hormonal and metabolic regulation. Its approach offers unique insights, allowing for more personalized prevention and treatment strategies. The question is, how do we measure insulin resistance? Well, insulin resistance is assessed using surrogate markers like fasting glucose and fasting insulin. However, accurate measuring insulin resistance requires personalized laboratory techniques. The hyperinsulinemic euglycemic clamp is the gold standard, measuring how much glucose is needed to maintain normal blood glucose during a steady insulin infusion. However, hyperinsulinemic euglycemic clamp does not account for the insulin sensitivity after meals, meaning it primarily assesses fasting state insulin action rather than postprandial responses. These limitations make it less effective in evaluating how the body processes glucose following food intake. So the Matsuda index derived from the oral glucose tolerance test OGTT estimate whole body insulin sensitivity over time. HOMA-IR, a more practical clinical tool, calculates insulin resistance using fasting glucose and insulin level. A high HOMA-IR value indicates poor insulin response, increasing the risk of metabolic syndrome, type 2 diabetes, and other metabolic disorder. These tests are not commonly used in routine clinical practice or standard laboratory testing, and they are typically reserved for research settings. There is a simple way to estimate insulin resistance in the clinic that relies on routine blood tests for triglycerides and glucose. It's called the TIG index or triglyceride glucose index, which is a surrogate marker of insulin resistance. It serves as a cost-effective alternative to a more complex insulin resistant assessment like HOMA-IR or a Matsuda index. Insulin resistant cutoff is placed at a TIG index value of 4.49 with high sensitivity and specificity values of about 82%. This represents the equation used to calculate the TIG index. However, you can easily compute the TIG index using an online calculator. Just simply input your triglycerides and glucose values, and the tool will automatically generate the result. Okay, the study identified a higher triglyceride glucose or TIG index as being associated with an increased risk of new onset diabetes among Chinese adults, highlighting its potential as an early indicator of diabetes risk. Additionally, the TIG index, recognized as a marker of insulin resistance, demonstrated a non-linear relationship with all-cause and cardiovascular mortality in the general population. TIG index and cardiovascular risk, the higher TIG values were associated with an increased likelihood of MI, strokes, and cardiovascular related mortality. Research studies often apply varying cutoff values for the TIG index depending on the population, methodology, and specific health outcomes being assessed. For example, in this trial, a higher cutoff value was used. Now, what are the different cutoff values? More than or equal to 8 versus more than 4.49. Some studies consider TIG index of 8 or higher as an indicator of high insulin resistance, especially for predicting diabetes or cardiovascular disease. Meanwhile, others use TIG values above 4.49 or similar lower threshold to detect early metabolic dysfunction even in healthy individuals. Now, different organizations including WHO, IDF, NCEP, ATP3, and various regional bodies have distinct diagnostic criteria for metabolic syndrome. These differences contribute to variability in metabolic syndrome prevalence across populations. According to the IDF, an estimated of 20 to 25% of the global adult population is affected by metabolic syndrome. Now, the global burden of metabolic diseases, data from the Global Burden Disease 2000 to 2019, a consortium of metabolic disease. The study examined 8 standardized death rate and disability adjusted life years or dailies for 5 major metabolic diseases from 2000 to 2019. The overall trend in death from 2000 to 2019 steadily increased, with the highest absolute burden in obesity, followed by hyperlipidemia, type 2 DM, hypertension, and NAFLD, with similar trend in dailies disability adjusted life years in a metric used to measure the overall burden of disease. While the distribution of mortality across various diseases is presented both globally and regionally with a breakdown by male and female population. Obesity again is the most prominent cause, represented in pink, followed by dyslipidemia shown in light blue. In Southeast Asia, the trend follows a similar pattern, with obesity being a major contributing factor. Now, the key components of metabolic syndrome is number one is abdominal obesity, considered a major risk by most guidelines, particularly the IDF and WHO, due to its strong link to metabolic dysfunction. Number two, insulin resistant, which leads to abnormal glucose metabolism, increasing risk of pre-diabetes and type 2 diabetes. Number three, hypertension, a significant contributor to cardiovascular complication, often present in individual metabolic syndrome. And number four, atherogenic dyslipidemia, which is characterized by high triglycerides and low HDL cholesterol, increasing atherosclerosis risk. Now, the question is, can obesity cause hypertension? If yes, how? Now, obesity is the major contributor to metabolic syndrome. In fact, plays a key role in hypertension. Now, the excess fat tissue activates both the sympathetic nervous system and the renin-angiotensin-aldosterone system, leading to elevated blood pressure. Sympathetic nervous system overactivation increases heart rate and vascular constriction, raising blood pressure. RAS dysfunction, angiotensin 2, narrows arteries, while aldosterone causes fluid retention, leading to higher blood volume and pressure. And this combined effect makes obesity a significant driver of hypertension and cardiovascular risk. In addition, obesity-related adipocyte dysfunction disrupts adipokine balance, influencing hypertension through endocrine and paracrine effects on endothelial cells, vascular smooth muscle cells, and macrophages. This imbalance affects vascular function and blood pressure regulation together with neurohormonal activation. Now, central obesity, often regarded as the primary risk factors, and excess abdominal fat is closely tied to insulin resistance and inflammation. This excess lipid intake overwhelms adipose tissue storage, causing triglycerides to be redistributed to the liver, muscles, and pancreas via VLDL, triglycerides, and LPL. This increases circulating non-esterified fatty acids and triglycerides, leading to fat accumulation, insulin resistance, and elevated blood glucose over time. On a cellular level, insulin-resistant disrupt insulin signaling pathway, controls glucose metabolism through PI3K-AKT activation, enhancing glycolysis while suppressing gluconeogenesis. Moreover, ceramide buildup due to de novo synthesis of from saturated fat also suppress AKT activation and cause mitochondrial dysfunction. Additionally, excessive lipid accumulation raises diacylglycerol level, triggering PKC overactivation, which blocks insulin signaling and contributes to insulin resistance, which is a key factor in type 2 diabetes. Now, excess fat buildup disrupts adipocyte function, leading to abnormal fat accumulation, and as a result, excessive free fatty acid overflow into vital organs such as the liver, muscle, heart, and pancreas, triggering insulin-resistant mitochondrial dysfunction and metabolic disorders. These include hepatic steatosis, elevated VLDL secretion, and NAFLD, hallmark of type 2 diabetes. Now, the research consistently demonstrates a high prevalence of dyslipidemia among individuals with metabolic syndrome. Several studies provide compelling evidence to name the different studies. These studies demonstrate the strong link between metabolic syndrome and dyslipidemia. While the exact prevalence can vary depending on the population studied, it is clear that dyslipidemia is a common feature of metabolic syndrome. So the link between insulin resistant and metabolic syndrome, insulin resistant enhances lipolysis, raising free fatty acid level in the liver, which leads to triglyceride accumulation and excessive VLDL production, resulting in liver fat buildup. This triggers oxidative stress, lipid peroxidation, and hepatic inflammation, contributing to muscle. Additionally, associated inflammatory markers are linked as atherosclerosis, coronary CAD or coronary artery disease, and diabetes as insulin resistant worsen hyperglycemia. What is the underlying mechanism linking insulin resistance to increased triglycerides and decreased HDL level? First, insulin resistance enhances triglyceride breakdown in adipose tissue, increases hepatic VLDL production, and raises blood triglyceride level. It also alters lipid exchange, leading to cholesterol, depleted HDL, and small dense LDL through activation of CETP, a lipid transfer protein. Additionally, chylomicron remnants are recycled in the liver, further driving VLDL synthesis. Behavior of adipokines depends on the status of an individual. In healthy adipose tissue, anti-inflammatory adipokines are elevated, while pro-inflammatory adipokines remain low, supporting metabolic balance. However, in obese adipose tissue, this pattern reverses with increased pro-inflammatory adipokines and reduced anti-inflammatory adipokines, heightening the risk of cardiovascular and metabolic disorders. So therefore, metabolic illness is linked to imbalanced adipokines activity with increased pro-inflammatory adipokines and reduced anti-inflammatory adipokines. This disruption affects appetite regulation and contribute to liver steatosis and promote cardiovascular atherogenesis. Additionally, it interferes with pancreatic insulin production, reducing insulin sensitivity and increasing the risk of metabolic disorders. Now, recent findings shows that gut microbiota dysbiosis play a role in metabolic syndrome by triggering inflammation, insulin resistance, and obesity, which can progress to heart failure. This further compromises intestinal barrier function, perpetuating dysbiosis and chronic inflammation. Additionally, microbiota imbalance affects adipokines regulation, leading to oxidative stress and endothelial dysfunction, increasing the risk of CVD, CKD, and muscle D, ultimately contributing to cardiorenal hepatic dysfunction syndrome and highlighting shared pathophysiologic mechanism. So in summary, obesity primarily results from an energy imbalance, but its causes are highly complex, influenced by biological, environmental, and genetic factors. Obesity is marked by enhanced lipogenesis, which stimulate adipokine secretion, including pro-inflammatory adipokines that disrupt metabolic regulation. Dysregulated adipokines contribute to the following. Number 1, insulin resistance stimulates beta cell to overproduce insulin, which is known as hyperinsulinemia, eventually causing beta cell exhaustion and leading to hyperglycemia. Secondly, adipokines dysregulation stimulate RAS and sympathetic nervous system activity, driving neurohormonal imbalances and results in hypertension. Thirdly, adipokines dysregulation disrupt lipid metabolism, increasing triglyceride synthesis and VLDL production. Insulin resistant raises free fatty acids, which the liver absorb high triglyceride level, destabilize HDL, accelerating its breakdown and worsening atherogenic dyslipidemia. Lastly, adipokines imbalance promote visceral fat storage, fueling central obesity and increasing metabolic risk. Now, the pathogenesis of obesity is not as simple as increased food intake and reduced energy expenditure. Obesity is the result of an interaction between the modern environment and our biology. Obesity happens when our biology or genetics, which evolved to store fat, clashes with the modern world's high calorie food and sedentary lifestyle. It's a society or societal issue, not just personal choice. Understanding this is crucial as effective management depends on tackling both biological and environmental influences. Now, the complication and consequences of obesity and metabolic syndromes are interconnected with shared risk factors and overlapping pathophysiologic mechanisms. You can see the arrows moving in various directions, right to left, up and down, representing the dynamic interplay between these conditions, highlighting their shared mechanism and illustrating how they lead to cardiorenal and hepatic dysfunction through systemic metabolic disturbances. Additionally, condition or the expanded complication of metabolic syndrome includes hyperuricemia, polycystic ovarian syndrome, obstructive sleep apnea, and even certain cancers. So again, just to emphasize the role of metabolic syndrome in cardiorenal and hepatic disorder, diabetes and obesity or diabesity contribute to the development of cardiorenal syndrome and hepatic dysfunction due to shared pathophysiologic mechanism. This includes hyperglycemia, hypertension, dyslipidemia, and obesity, which collectively form a cluster of risk factors recognized as metabolic syndrome. The effect of metabolic syndrome extends well beyond the heart, kidney, and liver. It also poses serious threat to brain health. Chronic inflammation and metabolic dysfunction linked to metabolic raises the likelihood of cognitive impairment, neurodegenerative disorder, and reduced brain function alongside the more recognized risks like heart disease, liver steatosis, and kidney issues. As a result, effectively managing metabolic syndrome is crucial to preserving overall health, including cognitive well-being. So finally, the cardiorenal hepatic system are interconnected in metabolic syndrome, sharing common pathophysiologic mechanisms like inflammation, oxidative stress, and lipotoxicity. This relationship are bidirectional. Heart failure worsens renal and liver function, while hepatic dysfunction exacerbates cardiorenal syndrome, and liver steatosis increases the risk of cardiovascular disease, chronic kidney disease, and diabetes by promoting insulin resistance and gluconeogenesis. Muscled individuals face heightened cardiovascular risk, reinforcing the complex interplay between these organ systems. So, in summary, metabolic syndrome and multi-organ dysfunction are interconnected through a chronic abnormal metabolic environment. Metabolic syndrome worsens cardiovascular, renal, and hepatic conditions, while dysfunction in these organs amplifies metabolic disturbances. This bidirectional cycle reinforces disease progression, leading to deteriorating health outcomes. So with that, I'll close my presentation and thank you again for listening.